we're going to give a pediatric perspective, an update on, there are a bunch of tools that are available, how do we, the things that pediatricians could use, and I'm going to give you my own point of view. And when I do that, I have to confess that Barbara and I, as you know, are involved in Chattis, and so we may be biased. Right. I'm sure everyone knows that the American Academy of Pediatrics has put out a mandate for universal screening at the 18-month visit or the 24-month visit, or if people have a 30-month visit, then that would be acceptable also. And the rationale for this has been that early intervention has been proven to be effective, and the earlier the better. And that was based on a review, there's National Research Council and other reviews, and we're going to come back to that. And then they say, well, if there's early interventions effective, there's evidence for it, and they're good screening measures, and the AAP has a number of them they recommended, but in their kit, it's the MCHAT-R that is being recommended. Well, here we are in 2015, and I don't know if you've seen in the newspaper, but the U.S. Preventive Services Task Force reviews areas where there's evidence for screening, and I'm not even sure if the report's out yet, but they question the adequacy of these screens and for toddlers, and also the evidence that intervention, and particularly intervention from a screen population, has been shown to be efficacious. So a lot of the studies were done on siblings of autistic kids, but they weren't done on kids who just got identified by being screened. So that's an issue. We have someone from Canada, and in Canada there's a particular voice there that Canadian researchers, was a CNN topic, call for more studies, and this was done in 2011. There was a pediatrics article, and they question also the issues of cost efficacy of early intervention. Since then, I'll say last May, there was, and they followed up with a study looking at just that, and what is the cost benefit. And an Ottawa intervention study showed that there was a cost benefit for earlier intervention versus standard intervention. In that article, they said there was lack of availability of a good screen, but they actually said MCHAT was promising, and we're going to think that through a little bit with you today. There are some other caveats that we wanted to review here. One is initially the MCHAT is the most popular screen, and everyone's familiar with that one, I'm sure, on the call. This was done by parent response, and but actually in the studies they also called up the parents and they asked, "Are you sure about this?" and sort of reviewed things with them. And then a later study came out and provided some structure to the review and called it the follow-up interview. They said in 2008 that this was highly recommended because it reduced the false positive rate by 90%. You know, many less parents being freaked out by the diagnosis of possible autism and less of a burden on the early intervention programs. So they now say there's a two-stage procedure. The MCHAT isn't just the parent screen anymore. The second part of the two-stage, the follow-up structured interview, is, in the words of the authors, required. They say you shouldn't be using the MCHAT at all if you're not doing the follow-up interview. But one of the issues that we find is that in all the data, the validation process, they used a research assistant on the telephone, and when they documented, it was a couple months after the initial screen. And we're going to come back to why we think that's important. And then there's this, is this feasible? Is it feasible to do in an office well-child visit. You've got a 26-page algorithm, and we wanted to explore to see whether we could facilitate this through Chattis, so that when there's a positive screening, we would prompt doctors to do the follow-up interview, and that we'll only give the questions from the exact structured manual in order to either confirm or refute the diagnosis. And we found that it just took a few extra minutes and way less than it would take to tell a parent that their kid might have autism, that they have to do something about it. And so this is some of the data that we have. And in this study, these were pediatricians in Maryland, and they did the follow-up interview during the course of a well-child visit, and then at the Kennedy Krieger Institute, a trained research assistant repeated it, and the agreement was very high. There was no significant difference in predicting whether the child had autism or not from the pediatrician's interview using Chattis at the visit than doing it later at Kennedy Krieger or on the phone prior to the visit. So this is, for those of you who haven't seen it, I think everyone I've heard is familiar with Chattis, and this is the place where the detailed report where you get a heads up on a child, and you can see that this child was positive for the MCHAT, and over on the right with where it says follow-ups, you get a chance to punch in and get into the world of the follow-up interview. And so you will get thrown to the right question, and I'm going to show you some examples from Chattis. Here's the first part is a more there's specific questions, and it's sort of, did you really mean it? You know, the questionnaire, you reported your child does not show things by bringing him to you or holding him up for you to see, not just getting help but to share. Is that correct about your child? So it's sort of, did you really mean it? Repeating the question. That's the first part of the structured interview. And then so this is the sort of questionnaire that faces the doctor, and they're going to check yes or no. And then the structure of this structured interview is to ask for specific examples. So then the parent will say what happens, and then you say, well, sort of what kind of response was that? Is it a pass response or a fail response? And that gets scored by the clicking of the clinician. And then there's another question. It's kind of a confirmatory. So is this sometimes just to show you and not to get help? That's a fine distinction. So what happens is parents go through these questionnaires. Sometimes they will misunderstand them. Sometimes they will be careless. And by face-to-face reviewing it, you can reduce the rate of false positives. There's another caveat we found as we thought about this MCHAT that we were providing for people around the country, Chattis, and that was young kids. And in this is a study by Pandy and the authors from the original MCHAT. And by the way, in a lot of these studies, they mix in high-risk kids who are waiting at early intervention programs to get a diagnosis. The low risk would be kids in the community who saw their pediatrician and were screened. And so if you look at the low risk, the younger kids, the younger toddlers, had a lower positive predictive value. That is, the percent chance that a positive actually had an autism was like 28% here. So what are the issues in younger toddlers? And there are some prospective studies that really show that autism symptoms are emerging gradually. But the MCHAT says yes or no. It doesn't say, well, how much? Is it just a little bit? And maybe that's an issue. So we wonder about that. We also saw that a standard language measure, a really nice measure called the MacArthur Communicative Development Inventory, may improve accuracy of review of autism symptoms. So we were interested in that. We did our own study, and I'll show you this because this was in Maryland. You screen a lot of kids, and a lot of parents don't consent. But we didn't have the parents all came from screening, primary care. They weren't people who were already waiting in the waiting room of clinics. But still, you lose patients from attrition, so it's not that generalizable as we like. And I'm going to show you a lot of results here, but what I want to show you is that we also found a big difference between less than 20-month-olds and greater than 20-month-olds, and in the positive predictive value. This is the MCHAT, and you look here at the over-referral rate, 53% over-referral rate if it's just an MCHAT. If you do the follow-up in the younger group, you're going to get a 13% over-referral rate. And by the way, in the older group, we're getting a really nice 0.96 positive predictive value, only 2% over-referred. It's really working out well for that 2-year visit. And now we did some exploratory stuff here. We did some analyses where we said, well, they had an ASQ. We'll take information from the ASQ, and then we took that MacArthur Communicated Development Inventory, put language items together, and it looks like we could really improve prediction of the less than 20-month-olds just as well as the older 20-month-olds using this combination screen. This is not ready for prime time. We now, that people in Maryland know that we're, NIMH has given us a chance to replicate this. We think that when you go through your data and you get the best cuts, you really need to replicate that, and I'm going to show you why. So we were wondering about what's going on with 18-month-olds. So we looked at, we've got a lot of data in Chatham. There's almost 100,000 cases we looked at, 18 months and 24 months, and we were thinking something different's happening under 20 months. And then you look at the failure rate, the item failure rate under 20 months versus over 20 months. Even if you adjust by prematurity, we thought, well, maybe some premature kids got in there because they were administered by chronologic age, as MCHAT does. But that didn't even make a difference. The younger kids were failing more often, and that one of the reasons to screen again at 24 months is that there is a natural history is that about 30% of the kids will regress who actually didn't have any signs of autism by 18 months. There should be a higher failure rate in the 2-year visit than the 18-month visit. That wasn't the case. We wondered what's going on, and we had some ideas. And this, I won't go into the details here, but basically we thought, there are some items that are kind of developmental items, and kids are just on the cusp of doing some of these things at 18 months, and some normal kids may not have done it yet, or quite yet. And it turned out that when we independently rated the items for ones who are on the cusp of development and other ones that are not, it was more the items that are on the cusp of development that explain the problem. So we thought, we're thinking now for 18 months. The MCHAT follows the so-called KISS principle, keep it simple, stupid, and it's the same score for every age. You just add it up. It's really very simple. But maybe for 18-month-olds, there needs to be a different kind of score, and it may be scoring that involves other variables, and it may be groups of kids that are scored differently. And we call it the DIS principle, because actually the computer can spit out the score and will weigh in some of your ages and stages and so forth. That's not ready. This is just sort of where we're at and what we're thinking, but we do think there's a problem in 18 months, not at 24 months. At 18 months, we think if the child is positive, you may want to wait a little bit till 20 months unless it was more very positive. And if parents have concerns, of course, we'll always make a referral. But so we have some caution at 18 months. How do we get at, what are some of the other tools used to assess autism? And there's no question that you've probably heard about the ADOS and the ADI revised. These are the gold standard tools. The ADOS has 5 modules, and one is just for one new one just for toddlers. This is observations, and they're structured tasks. The ability to respond to other people's actions, social reciprocity, that social communication is, and restricted repetitive behaviors. Those are the 2 pieces of the DSM-5 definition of autism now, and there are plenty of items that elicit those kinds of behaviors. And then there's the autism diagnostic interview. This is a really detailed interview, a full developmental history. There are 93 items. They cover, early development, loss of language, social development, play, so forth. Now, together, these things, and so these are not tools that look like they're going to gain favor in primary care. It takes 2.5 hours, and you need to be rigorously reliable, certified until you're allowed to do the ADOS in particular. There are other kinds of things on the horizon. People wonder maybe there's going to be a genotype that you could, and someday there may be, an MRI or EEG. And when people try to create algorithms in all kinds of ways, they're getting some accuracy, but that's certainly not available right now. So these are observation tools, the ADOS observation tool. Take time, probably not things that pediatricians are going to do. But here you have, 2015, the Rapid Interactive Test for Autism in Toddlers, the RITA-T, 10 minutes, okay, 2.5 hours down to 10 minutes. How cool is that? Very high specificity, or sensitivity and specificity. Now, caution is that this has not been replicated. It's a group of toughs, and what they're doing here is looking at a group of kids who come to a clinic. Now, you have to be suspicious. This is not the kind of kids in your own clinic. This clinic probably has a label out there that says autism clinic. So maybe half the kids already are going to have autism. So if you flip a coin, you're going to do pretty well. Not like 1%, like more like 50%. So you have to pay attention to the population. This is not ready. This needs replication for sure. This is interesting. And there's another one, the SORF. This one was a re-videotaping of an observation system. They looked really hard. They got 94%, they said, differentiated as autism from typical and developmental disabilities. This certainly needs replication and not so practical for pediatrics. You've got to do a video analysis. That doesn't sound like something pediatricians are going to do. But here we have the STAT. The STAT is a 20-minute play-based. There are 12 interactive items you request, directing attention, motor imitation, that kind of stuff for 2-year-olds to 35 months. And it has some good sensitivity, and it has been replicated, and has good inter-rater reliability with pediatricians. There is one that pediatricians are using. There is a web-based component to training and a process. If anyone's interested in learning more about how to get trained, we can put you in touch with the trainers who are CADIS users, and we know well, but we're not supporting that ourselves. So that's something to think about if you want to get extra training to come up with a recognized pre-diagnosis. So now, how about the older kids? All that is really for young toddlers and up to 3 years. So I told you that the diagnostic interview had 90 items and took an hour and a half. Well, you know what? The same authors took it and they said, well, how about putting in a parent questionnaire? Yes, no. And so there's the social communication questionnaire. And it is pretty reasonable. It actually didn't do better than the MCHAT in younger kids, less than 4 years here. But actually for 8 to 10-year-olds, it was pretty good. It had reasonable sensitivity and specificity, and the positive predictive value was high. So it's a useful tool and a simple tool for parents or teachers to fill out. And there are two versions of it. One is the ever version, and the other is the current version. And I'm sorry, this is a little hard to read, but these are sample items. Has he or she ever had things that he or she seemed to have to do in a very particular way, or order or rituals that she insisted you go through? Yes or no? So questions like that. That's available. It's available in Chattis too. Another one that looks promising for older kids, and this is the Autism Spectrum Screening Questionnaire, ASSQ. This was studied well in Norway, and is good sensitivity, very good sensitivity and specificity, and this was in 7 to 9-year-olds. One caution is that to get those levels of predictions, you needed to have parent and teacher data both, and the other caution is the positive predictive value is still low with that, with 0.36, which is about half the predictive value as the social communication questionnaire. Now, when you get older kids, we're talking about interviewing data. And you know, when you get to 18-month-olds, there's not much history of autism symptoms to review. And they don't even use the diagnostic interview with the very youngest kids, with toddlers. But when you get older, there's really advantages. And so what I'm suggesting is that what pediatricians are good at is interviewing past histories. And the reason for that is that if you're going to observe, and you need to observe, that some symptoms have low frequency, you may not see it. And some symptoms are more apparent when kids are younger. So the data is that ever trumps current. And so I want to talk to you about two tools that are called multidimensional tools, where multidimensional means you get all the information you have, and it's a clinician rating, the CARS and the CSD. And these things are notable. We're talking about older kids, we're talking about lower functioning kids, and now we're talking about those high functioning kids who may be very bright, used to be called Asperger's, we don't call them that anymore. So there's the checklist for autism spectrum disorder. It covers high functioning and low functioning, 15 to 20 minute structured interview with the parent, and again asking if symptoms were ever present, and you get greater than 15 score, and it has a very high hit rate. And the norms come from 630 children, wide range of ages, and this is from observation of the child, any information you know about the child, and as well as so their ratings, but in addition to the questions you're asking. And here's how it looks. And in Chattis, you're asking these questions. You could have the parent do it in advance and then review it. It would be one strategy. Checklist for autism spectrum disorder. Now, I want everyone to know about the CARS. This is the Childhood Autism Rating Scale. This is the granddad of these all these tools. In 1986, Eric Shopler at UNC initially validated this on 1,600 children. Now it's a CARS 2, a revision on some 2,000 children in 2010. This is the most thoroughly studied tool of its kind, or any kind actually, for autism, and it's the most practical. And I suggest there's even a place here for pediatricians. And the CARS 2 has two versions. There's a standard version, ST it's called, for kids less than 6 years or kids who are older but have limited intellect, less than 80 IQ, or poor verbal skills. And then there's another form called the HF, high functioning version. And the new one is the HF, and what it adds is that there are emotion-related items asking a child's point of view that you wouldn't be able to get at in kids with less capacity. And so the clinician ratings come from observation plus parent interview, any teacher data, and then with the CARS 2, they have a companion tool called the QPC, Questionnaire for Parents or Caretakers. And this is a tool that collects data. It is not scored. It is a data collection tool used for the clinician rating tool of the CARS. And the CARS ratings go from a 1, which is considered normal, to 4, which is severely abnormal. And each of these anchor points has a little definition. And if you're in between two definitions, you can take a 0.5. And the idea here is you're judging for the peculiarity of the response, intensity, frequency, and duration. There are 15 subscales. There's a cutoff for ASD, but you could also see, say that now with the DSM-5, and we've taken away these categories of, the Asperger's and PDD, and you have no other way really to assess severity, and that's important. So this is one that has a broad scale, 15 to 60, where you can assign a severity scale. And the validity data is quite good. 92 to 98% sensitivity in studies range from 0.79 to 0.92. Specificities are in the mid-.80s. And with other measures, that's with clinical diagnoses. With DSM-4 criteria, there's one study they hit 100%, another 88%, and compared to the ADI interview, 86%. So this has something, some credentials behind it. Oh, and the cool thing about the reliability part is that there's data on the accuracy for clinicians with limited experience with autism or the tool. That's surprising. Now, the authors will say, and all of autism diagnosis has to do with, it's all predicated on the clinical diagnosis and the clinician's experience with kids with autism. And they will say that you need to have a lot of information and be good at observation. But there is data that even pediatricians might be able to use a tool like this. So here's what it looks like. This is the parent side. And there, for each item, this concept of is it been in the past, like the ever, off, and frequency is there, and judgment of how much of a problem, and then asking for examples for each one of these. So let me show you what we've done with this CARS. We have taken all the data from the parent form, and we have a way now to integrate it. We reviewed this with the CARS authors, and they're feel like this is a good efficiency. So here's Chattis, and you can see the questionnaire that was done, and you can do a follow-up, just like you could do the follow-up for MChat. You can click over here for the standard, or I want to use the high functioning, and bingo, the data from the parent, that's the red part, is integrated with the ratings that the clinician, you are doing. And you are looking at this and reviewing what the parent said and asking them more about the examples and watching the child to come up with your own rating. So you do that, and then we're going to give you a score, T-score, percentile, and rating for the 50 different components. So we think the CARS may have a place for getting a further grip on, is this autism And by the way, I think you could probably charge, since this is a standard evaluation, of $96111, which is like $140. So it's worth knowing about. Okay, now we're talking also about older kids and high-functioning kids, and kids who you can talk to. They're not just the obvious kids who are spinning and slapping their hands, and you can tell they have autism without a big test. But how do you observe these kids who may look perfectly fine? So the concept of theory of the mind is one that you can pursue if you know how to ask about it. Now, theory of mind is a very interesting notion. It's the ability to understand other people have different intentions, desires, beliefs, internal ideas that are different from the objective reality. It's the ability to understand that there's such a thing as a false belief. But somebody else can have the wrong idea about a situation because they just don't have access to the knowledge about it. So their mental belief is different than the objective reality. That's theory of the mind. And the whole idea that this develops, it develops normally at about 4 years of age. Normal kids will have it. And then they've developed theory of the mind tasks. So if I was with a older child and there's an issue of autism, and this is a verbal, bright kid, I might ask them one of the theory of the mind tasks. And we have taken these cartoon illustrations I'm going to show you to illustrate this, and as a clinician tool, you could show this story and tell the story, but the data on this cartoon. This is Sally. This is Ann. They're in art class together. See this box? This is a crayon box. Before recess, Sally puts her crayons in the crayon box. Then she leaves to play outside. Then Ann comes into the room. Ann needs a place to keep her crackers. So she takes the crayons out of the box and she puts her crackers into the crayon box. What really is in the crayon box? Did Sally see Ann put the crackers in the crayon box? Final question. What does Sally think is in the crayon box? That's the task. And really simple. Do they have the idea here, and there are other tasks like this? Does the child think that, of course, that the crayons are in the crayon box because that's where they are, that they not realizing there's the possibility of a false belief because the other person wasn't there in the room. So I'm going to stop now and ask for questions.
Hi, Dr. Sterner.
Yes.
Hi, it's Larry Shabuk in Vancouver. A couple questions. I think they're related. At the present time, what's the average age that a clinical diagnosis is made of autism?
Average age.
ASD?
Yes.
And then
well, it depends. Yes, go ahead.
The follow-up question is there such a thing as a risk-benefit ratio to earlier diagnosis?
Right. This is the Canadian question about risk-benefit. Perfect. Thank you for being here for that. Well, it depends on what country. And in this country, it was over 5, and the CDC has it close to 4 right now as the average age of diagnosis.
Although it does vary with severity. So the more high-functioning individuals are diagnosed later. So
right.
People who used to be called Asperger's, the average was 8 years old.
That's right.
And of course, the more severe ones are identifiable younger.
Right. And so the question that the Canadians are asking is, what is the risk-benefit ratio? What's the benefit? There were studies, several studies of ABA therapy, and if you started earlier, you get further. Let's just say that. And that's a question. And your colleagues in Ottawa, I'll show you back at this slide, actually did a cost benefit, and they said there was it cost $8,600 less for the program if you started earlier, and they figured $45,000 less cost per dependency years. That's one calculation of that. So there is some data on that point. What we don't know is kids who were screened in a community sample and were randomly put into early intervention versus wait list controls. That hasn't been done, and that's why the question the U.S. Preventive Services Task Force is holding back their endorsement. Does that answer your question?
Right. Or I'd like to hear. Actually, I'd like to hear your point of view, Dr. Shibuk. Are you a developmental specialist?
I'm not. No. I'm an adult psychiatrist, and I don't
Great.
I see.
I don't have any experience or training with autism. I just work in a clinic where there's a lot of autistic patients, but not as a clinician. So it's more of a personal interest as well. I mean, I have some training in pediatrics, but it's kind of more of a theoretical issue relating to the trend of earlier and earlier diagnosis of conditions and the risks associated with that.
And is there a particular thing that you would be concerned might happen with kids who have early identification?
I don't know. Actually, I don't know. The only thing I'm familiar with is the risk. And actually, this wasn't in the medical literature. I think it was in the New York Times, where teenagers were given screenings for suicide risk by teachers. And it actually led to poor outcomes because the students were then sort of ostracized and labeled. I mean, I don't know anything about autism, so I can't say if anything like that would be happening. But I would be a little bit concerned about daycare, parents' reactions, and things like that if a label was put on at a really young age.
Yes. Yes.
Those are good thoughts. Maybe Emily, who's our child psychiatrist, would like to pipe in on that too.
I'm not sure I'm following the question.
So is there a problem with early identification? In other words, is there a cost to early identification that you could imagine?
Only if we're incorrect, I guess, but no, I don't think so. The interventions are going to be focused on improving social skills, parent support. I don't think those are harmful in any way. Early identification is not, we're not going to put kids on medication as a result of early identification typically, and so I don't see that the social interventions would be harmful.
We think there's other data converging on the idea of overtraining early, like dyslexia, where we know this aggressive intervention in the early school years can make a difference in their neurophysiology and functional MRIs later on, and sort of the relatively critical moments of developmental change. And the notion, and it's just the notion we don't have fMRI data on these kids, is that may be happening. That we're training kids in preschool on what's called the pragmatics, the way to communicate things that come intuitively to people who don't have autism, and overtraining can develop these skills. And so there is a growing rationale for it. And I think that the main cost of early screening I see is that you can worry parents because of false positives, and you can overload the system, diagnostic system. That's an economic issue. But you can, the 90% false positive, there are a lot of parents who are going to be distraught.
I think some other ways to think about it. This is Barbara Howard, and Larry, I'm also a developmental behavioral pediatrician, like Dr. Sterner. I see a problem in the sense, a potential problem in the sense that you might say, well, if there's nothing wrong, you may make kids think there's something wrong. But in fact, I think it works the other way around, and that is helping kids with things. The kid and the parents, not so much the kid with insight, but the parents certainly know when there's something wrong and appreciate people addressing it. We have much more of a big problem in the other direction, and that is the doctors say, well, I think he's okay. And the parents really don't feel that way at all. They think there's something wrong, and then they lose trust in the medical system or the educational system, as well as continuing to be worried. So you could look at it. You could look at that way as well. And as Emily pointed out, these are mostly social skills training. Even though there was an ABA study, most intervention is really not very strictly ABA. That's really for the most low-functioning kids who clearly have the problem. There's a lot of things that can be done that's more like play. And so I think it's good to think about what's happened in the American educational system is now something called response to intervention. I don't know if they do that in Canada or not. But even for kids with learning disabilities, the first tact is use some extra support and intervention and see how they do. And if they do well, then you don't sort of keep them in the full gamut of learning disability services. So it's a little bit like that in that kids can actually graduate from services as well. So I think we ought to keep that into account.
These are intensive services. And these on the other hand, in these interventions that are proven, they're giving them like 30 hours a week. This is not just a little bit and see how it goes. But they can graduate from it, and this is happening before their self-concept is really crystallized.
Right. It's not the kid's self-concept, except it's more about how